Hello, I'm going to make a presentation today of a very important subject which has a considerable interest in both the primary care as well as in the secondary care. The presentation is more in line with what the NHS expects of doctors in the primary care as well as in the secondary care, and the title is Dementia. So it's a composite of various kinds of dementia, and as to what dementia is, what the associated etiological factors are, how it is diagnosed, how it is managed, and then in the end, what the options are present with regard to management in the primary care as well as in the secondary care. It's a subject full of interesting innovation, modern research, but also relies on numerous matters of personal experience. It also involves the specialties of elderly care medicine, memory clinic, neurologist, physiologist, rehabilitation experts, and also those physicians who prevent dementia, who manage the risk factors relating to dementia, and who then subsequently manage the post-dementia problems. So I'm going to share my PowerPoint slide with you. The slides have been made in respect of NICE guidelines, chronic knowledge summaries, local guidelines, as well as numerous other associated publications in the BMJ learning, and also in relation to additional information on the internet. So how does one define dementia? Suffice it to say that it is an irreversible neurodegenerative syndrome which affects the cognitive and behavior control of a patient, and it eventually leads to memory loss, disorders of reasoning, communications, and personality changes. So it affects cognition, personality, and behavior. And it also is very much influenced by additional comorbidities. It's a disease which affects patients usually over the age of 65. So much so that if someone has dementia under the age of 65, then it is referred to as early onset dementia. So how does one understand the diagnostic elements of it? So one would regard an elderly person to be suffering from ageism, and there'll be numerous associated functional deficits and symptoms from there. But in dementia, there is much more than ageism involved. And the current criteria say that there must be at least two of the following cognitive problems: memory, and in particular, recent memory loss of control of language. So one would be speaking in a non-understandable, bizarre language. The behavior would be out of character and not following any logic or planning. There would be psychological features of misunderstanding in respect of orientation, visual cues, and disregarding various alarming features. Also, some of the intended functions, such as driving, would be considerably affected as the level of dementia increases. Using the same definition, if a patient has only one domain amongst these 4 or 5 that I've mentioned, then one refers to it as a mild cognitive impairment. So, how many people are affected by dementia? And WHO reports that at any one time, there are about 50 million people in the world suffering from some form of dementia, and that 10 million cases are added each year. And this information was supplied to the Office of the National Statistics in 2020. In the UK, the ONS has suggested that any one time there is just under 1 million patients suffering from dementia, and these are usually patients over the age of 65. And from that estimate, it is projected that by the year 2040, and that is between now and in 18 years of time, there will be a rise to 1.6 million people suffering from diagnosed dementia. So, in a nutshell, if you see the prevalence rate in the UK, and that it is 5% in people who are just above 65 years of age, and it is 20% between 65 years and 80 years, the average being 7.1%. But when the age exceeds 90, so between 90 and 94 years of age, the prevalence goes up to nearly 30%. That means every third person in this age group has dementia. One should readily understand from observational and research criteria that there are many kinds of dementia now seen. Some are of one type, such as Alzheimer's disease or dementia with Lewy bodies. Some are a mixture of the two. That means some features of one type of dementia and some features of the other kind. And sometimes one starts off with a particular kind of dementia, such as dementia with Lewy bodies, and then later in life develops a multi-infarct dementia in addition. But broadly speaking, there are four main kinds of dementia that we should be concerned with. Alzheimer's disease, the incidence of which is between 50 to 75%. Vascular dementia, also called multi-infarct dementia, which constitutes about 20%. Dementia with Lewy bodies, and that amounts to between 10 to 20%, 10 to 15%, beg your pardon. And frontotemporal dementia, which amounts to 2%. This is also known as the PIC dementia. We'll now talk about Alzheimer's disease. And in general, what is true of Alzheimer's disease will probably also be reasonably true of the other kinds as well. It's a disease which is pathologically characterized by cerebral atrophy, but it doesn't relate purely to the cerebral hemisphere, and it goes on to cerebellum and related structures as well. So atrophy takes place in addition to protein or amyloid plaques, which come in as plaques in various parts of brain and associated with a tangle of fibers, neurofibrillary fibers, made up of tau protein. So the result of that is there is localized inflammation, and the neurofibrillary tangles prevent appropriate and reasonable information transfer or signal transfer. And so when the tau protein becomes a little excessive, then there would be blockages of cholinergic transfers. And this is an essential neuromedium a transmitter which relays information from one set of neurons to the other, and therefore there would be significant cholinergic defects. Alzheimer's disease can also exist with vascular dementia, when a person is elderly with cardiovascular risk factors which lead to possibly ischemic or thrombotic events, leading on to multi-infarct dementia bit by bit. It is also known that when Alzheimer's disease affects younger people, such as those who are younger than 65, there could be a genetic or a family history, which, if investigated, might show that there would be chromosomal abnormalities at loci 14, 19, and 21. But basically, no one knows how and why Alzheimer's disease occurs. The vascular dementia, also known as multi-infarct dementia, is caused usually by multiple small or a single or two large infarcts. And as a result of this infarct, which occurs slowly, gradually, or suddenly, there will be angiopathy with deposition of amyloid tissue. Underneath the cortex, there would be arteriopathy as well, and this is referred to pathologically as autosomal dominant type, with subcortical ischemic infarcts. And this is associated with white matter deposits, leukoencephalopathy. And so subcortical autosomal dominant arteriopathy with subcortical infarct is referred to as CADASIL. Patients who have multi-infarct dementia may have some fleeting symptoms of TIA or hematurosis fugax. They might have posterior fossa symptoms due to infarct, leading up to gait problems, movement disorders, and incontinence. Another important aspect of this type of dementia is that there is extreme mood lability from depression to panic attack. If it occurs in a younger group person, that there may be a genetic cause. Clinically, one could diagnose vascular dementia if it develops within 3 months of a known stroke. Dementia with Lewy bodies is similar to Alzheimer's disease, but there is marked fluctuation in the cognition and visual hallucination, and there is considerable Parkinsonism. However, there is persistence of progressive memory worsening. And the main lesion is cortical and subcortical Lewy bodies. These are abnormal deposits of alpha-synuclein, which leads to various kinds of bodies called Lewy bodies, and it affects one's way of thinking and one's control of mood. Dementia with Lewy bodies can overlap between Alzheimer's disease and DLB. Full stop. This kind of dementia is suspected when cognitive symptoms predate Parkinsonism by 1 year. The abnormal deposits of Lewy bodies are not just seen with dementia, but also seen with Parkinsonism as well. This is why behaviorally it involves symptoms of extrapyramidal nature. frontotemporal dementia. It's called peak dementia because it is characterized by involvement with the fibers or neurons connected to the frontal lobe, and there is a considerable degree of disinhibition, which may be verbal, sexual, and also behavioral. It can occur in a younger person, and it's a common cause of young dementia, particularly when there's a family history of dementia as well. And pathologically, there is degeneration present in the frontal or temporal lobe. In addition to these four main types, there are other associations as well between dementia as well as other bodies as well. So there is a relationship which I have just mentioned between dementia and Parkinson's disease. Huntington's disease is also associated or maybe connected to dementia, and that this is related to a neurodegenerative condition, and there is mild cognitive inhibition or disorder with psychological overlay. Creutzfeldt-Jakob's disease, which does not have much to do with mad cow disease, but it is a neuroinflammatory disorder with some degenerative element, and some patients have stark dementia with it as well. Autoimmune disease, immune competence disease, inflammatory disease, including HIV, can be associated with dementia. Normal pressure hydrocephalus, chronic subdural hematoma, and benign brain tumors are also associated with a greater incidence of dementia. There are some endocrinological conditions such as hypothyroidism, Addison's disease, and hypopituitarism, and these are also sometimes associated with dementia. Hormonal problems such as vitamin B12 or thiamine deficiencies can be associated or linked to dementia. In people who have grand mal, if they have repeated fits with amnesia, these are also connected to the early development of dementia. There can be other causes as well, such as age. Old age is the strongest risk factor for dementia. Mild cognitive impairment can lead to dementia within 3 years, and such things occur up to 30% of the time. Patients who suffer from learning disability constitute about 20% when they are over the age of 60 in developing dementia. And if they have Down syndrome, then they have a greater incidence, such as of 75% in developing dementia. In terms of genetics and family history, when someone has a young onset of dementia and there is a 3-generation family history available, then they could have the mutated amyloid precursor, SEN1 or 2, which predisposes to some kinds of dementia. A study of CSF in suspected dementia can show apolipoprotein E from plasma as well as CSF. And this relates quantitatively to Alzheimer's disease. So the higher the level, the more the advancement of Alzheimer's disease. If there is existing cardiovascular disorder, or when multiple cardiovascular risk factors are present in the middle age, there is a greater chance of developing multi-infarct dementia. Cerebrovascular disease is a strong risk factor of multi-infarct dementia, and the risks increase by twice than if someone does not have cardiovascular disease. Parkinson's disease confers 2 to 6 times higher incidence of dementia, and 75% cases develop Alzheimer's disease after 10 years of suffering from Parkinson's disease. There are some modifiable risk factors which unfortunately are ignored or not considered, and that these have a significant bearing on the prevention and on the control of dementia. When there is reduced mental stimulation, as would happen in uneducated people, when sensory stimulation is reduced, such as with hearing loss, presbyacusis, visual loss of a substantial nature, when there is uncontrolled hypertension, when there is prolonged inactivity or immobility, when there is a history of smoking and obesity. So these are common modifiable factors which one can control. Surprisingly, drinking alcohol to less than 14 units per week may be protective as far as dementia is concerned, but exceeding this limit may lead to Alzheimer's disease. Presence of erratically treated type 2 diabetes increases the risk of dementia by 50%. Depression is also linked to dementia, and how close it is difficult to see, but depression is a common accompanying symptom of Parkinson's disease, and Parkinson's disease is very much like dementia. Low social engagements mean less challenges, less stimulation, and these are also said to be responsible as risk factors producing dementia. Some researchers have suggested air pollution due to nitrous oxide and also carbon monoxide contribute to early development of dementia. So, what are the features of dementia? So, first of all, we must identify that there is a cognitive problem, and then there is a behavioral problem, and then there is a psychological problem. So the cognitive impairment means there is loss of recent memory, there is receptive dysphasia, there is dyspraxia present, loss of organization in relation to orientation, there is disorientation, and as a result of all of these, impaired functions such as writing, reading warning notices, taking notes of warning signs when driving, looking at but not taking any action as far as cookers are concerned, and they can be switched on and left on when one goes out. Then the other group relates to behavioral problems. And so behavioral and psychological symptoms of dementia, PPSD, in a combined manner cause delusions. Something is unreal and you perceive it to be present. Hallucination, when something you know can exist, but it's not around, but you believe that it's around you. Agitation, emotional lability, laughing inappropriately, showing sadness when there is no need, visible depression, unnecessary anxiety, emotional flatness such as apathy. Doesn't matter whether it's good news or bad news, one doesn't respond because one doesn't understand that they need to respond. Social or sexual disinhibition, which can lead to forensics, and that means exposure, talking inappropriately, making injudicious, challenging remarks. And there are motor disturbances, such as doing things which are inappropriate, like seeing the cold tap running, one turns on the hot tap thinking it would stop the cold tap. Wandering, and this leads to significant safety and security problem, particularly when wandering out in an unprepared state. Repetitive activities such as doing things unnecessarily several times, cleaning, features of OCD are some of these kinds of features. And there is problem with sleep, excessive, untimely, and intermittent. So what does one mean by cognitive problems? So the Age UK and Alzheimer's Society relates to these kinds of things, which are supposed to be cognitive problem. Memory loss, others notice it first. Difficulty with finding words, so using inappropriate words. Dyspraxia. Difficulty with visual and spatial abilities, such as getting lost while driving in a direction which was said to have been familiar with. Difficulty handling complex tasks, such as not knowing exactly what to do when a postman drops a letter. Difficulty reasoning or problem solving, such as there is a voice message on the telephone and one listens to it and does not take any action, such as an important warning or request or something. Difficulty with planning and organizing, going to a shop and coming back empty-handed. Difficulty with coordination and motor functions, and when it relates to driving, it can be catastrophic. Confusion and disorientation. So all of these are cognitive problems. So what are the psychological problems? Personality changes. From being a quiet person, one develops aggression, anger, or extreme lability of mood. Depression, and this is mainly due to deprivation of sensations such as deafness, visual problems, not being able to interact with others, anxiety and phobia, that if the patient gets on to meet someone, they will become nervous because they wouldn't be able to answer any questions. Inappropriate behavior, laughing when it's a sad event, paranoia, similar to OCD, and having some sort of delusion, such as being watched, or whatever one does, one will get told off. Agitation, because of a feeling that one can't do anything right. And in helplessness, one becomes agitated. Hallucination, as we have discussed already. So how does dementia affect patients, carers, government, hospitals? So it is a kind of disability leading to dependence on somebody, such as a carer, and that the comorbidity will exacerbate it, or it can lead to further comorbidities. Low performance in activity of daily living, complex needs such as planning, cooking, recording on TV and recorders can't be done. There is problem with mobility and planning, and there would be problems of security if one wanders off. And when one lives in one's own room and doesn't mix up, there will be issues of isolation. And then the behavioral and psychological aspects occur in 90% of people with dementia. And these relate to agitation, wandering, incontinence, sleep. And then this will lead to new acute problems leading to urgent care or admission in the hospital. Often patients are unmanageable at home and need to be admitted to care homes or nursing homes. Office of the National Statistics records that in England in 2012, 14 to 58% deaths occurred from dementia, which had occurred in the nursing home or care homes. Employed carers can resign. Family carers cannot resign. And therefore, there are issues of carers' own lives, their own health being affected. And it becomes unreasonable. They would need respite to recover, and they would need additional support. There is considerable financial hardship because most age band is 65 plus when someone has retired and is using up assets and monies that have been collected over the years. Surprisingly, despite the government's assistance, which is considerable, statistics suggest that 66% of costs of management in care home or nursing home is borne by the patient or the family. So only 1/3 is paid for fully by the government, by the NHS. So if a doctor becomes aware of presence of or suspicion of dementia, not presence of, but suspicion of dementia in a patient, then what does the doctor in the primary care do? First of all, you'd need to make a clinical review of comorbidities and general health status. There should be a neuropsychiatric assessment. The neurological assessment would be the 10-minute neurological examination, and psychiatric assessment would be based on symptom discovery as well as information from the carers, and to document these. There would be routine investigations of an elderly patient who has some sort of cognitive decline. So one would want to rule out electrolytic disorders, anemia, various kinds of infection, autoimmune disorders, diabetes, whether there is dysrhythmia present, or whether there is a lesion in the chest. Then when dementia is suspected, having undertaken baseline investigations and clinical and psychological assessment, it would be prudent to refer the patient to the dedicated memory clinic or to the elderly care physician, who used to be known as geriatricians, or psychiatrists. During this time, one should attack on and control the modifiable risk factors such as alcohol, diabetes, cardiovascular risk factors, hypertension, obesity, and smoking. This is essential. So when the diagnosis of dementia is already made, what does one do in the primary care? Having assessed the patient clinically, neuropsychiatrically, and through tests, the information is given to patient and to the carer or the family, which is responsible for their care, giving them advice to look up information and to pass on links or handbooks or various kinds of leaflets from Alzheimer's Society or Carers UK. In the primary care, with the diagnosis of dementia, there would be forward planning. And that means sharing information with the patient and with the carers or family about lasting power of attorney, advanced directives, preference as to where the review should be made, and if necessary, where the end of life is meant to take place. The primary care actions ensure that there is a named care manager and that there is a regular reviewed care plan. And this is done on the patient's record so that it's automatically reminding the clinician that such a review is due. There would be a review by way of monitoring physical and mental health. And if the patient is on medication relating to dementia, whether there are side effects seen, and if the medications have been reviewed. One should have a low threshold in areas of doubt to refer the patients to the memory clinic or to the specialists, elderly care physician. The aim of such primary care action, as well as the aim of the referral, would be to maintain independence for the patient, controlling symptoms, and preserving activities of daily livings. So how does the specialist undertake the investigations? So the specialist would double check on the previous investigations and would make their own neuropsychiatric assessment. They would oversee whether there is effective control of risk factors. And then, of course, there would be imaging, CT scan, MRI scan, FDG PET or perfusion SPECT. If dementia with Lewy body is suspected, then further imaging is also undertaken. It is unusual, but sometimes to exclude other illnesses such as infections, autoimmune disorders, or bleeding. CSF study is also done. But this is nowadays reserved for a beta 42, that is total tau and p tau measurements. And of course, there would be studies of meta-iodobenzyl guanidine with a tracer to see which area is affected more. So these are imaging studies. The commonest ones are MRI and positron emission tomography, or single photon photon computer tomography. In addition to these imaging studies, it is important to consider providing, through rehabilitation and through advice, cognitive stimulation therapy. So, riddles, problem solving games, activities where one is motivated, even including painting, drawing, but having a theme so that one starts off, achieves the objective, admires it, and then moves on to the next activity. So, stimulation therapy is very helpful. Group reminiscence therapy is usually done in day centers overseen by experts in this kind of rehabilitation, where they describe their experiences, which offers stimulations to other people, as well as the reminiscence will also stimulate the person who is describing the event of organizing his thoughts, self-stimulating, and then delivering his speech or presentation. Some of the work-related functions, which are analytical in nature, calculation of bills, undertaking of certain tasks, such as one would do with management of the household, are done by the rehabilitation experts, and they teach patients what to do, advise carers to supervise, and then self-assess whether the performance is maintained or whether it is reducing. So we now come to medical treatment. And so, because the problem is of cholinergic involvements, the main treatment comes from acetylcholinesterase inhibitors. And the common agents used are donepezil, galantamine, and rivastigmine. Additional treatment is given or to other conditions associated with Alzheimer's disease with memantine hydrochloride or with antipsychotic medications. So these are the pillars of treatment. But when one treats patients with acetylcholinesterase inhibitors, what should be avoided should be anticholinergics such as amitriptyline, paroxetine, solifenacine, chlorophenamine. One should also avoid antipsychotics such as olanzapine and quetiapine because of the possibility of enhanced reactions, neuroepileptic malignant syndrome. One should avoid beta blocker. One should avoid enzyme inducers such as ketoconazole, erythromycin, quinidine, and fluoxetine. One should avoid antiemetics, particularly with metoclopramide, but in particular with rivastigmine. So these are the usual features of acetylcholinesterase issues. So in this group, as we said, it's donepezil, memantine, and others. So donepezil, galantamine, and rivastigmine. So coming to the donepezil, the initiating dose suggested by and prescribed initially by the consultant would be 5 milligram at night for 4 weeks. And if the patient then tolerates it, then it is increased to 10 milligram. And this is for 4 weeks, and this should then continue. The side effects of donepezil would be hypersensitivity, shouldn't be given in pregnancy and whilst breastfeeding. But the common side effects are nausea, vomiting, anorexia, diarrhea, fatigue, insomnia, headaches, dizziness, syncope, abnormal dreams, hallucination, agitation, aggression, muscle cramps, urinary incontinence, rash, and pruritus. One should have a cautious approach when the patient has already got a sick sinus syndrome, because heart block can become worse, or when one is on heart rate reducing medications such as bisoprolol, and if someone has peptic ulcer, if someone has antipsychotic medicines such as olanzapine, and that neuroleptic malignant syndrome can occur. But this is the most popular suggested medication in the group of acetylcholinesterase inhibitors. Galamantine can also be used, and it is used as 8 milligram per day for 4 weeks, and then 16 milligram daily for 4 weeks. And this should go on as a maintenance dose between 16 to 25 milligram daily. Side effects are slightly similar to those of donepezil. The important thing to remember is to monitor the patient's weight during treatment, heart rate, hypertension, syncope, and so on. Galantamine should be used with caution when someone already has a hepatic impairment, including Gilbert's disease, and when there is a combined renal and also dysfunctions. QTC interval can be prolonged. There would be electrolytic imbalance. Rivastigmine. It is used orally as 1.5 milligram per day, then increased to 1.5 milligram twice a day, every 2 weeks, eventually to a maintenance dose of 6 milligram BD. It can be used as a transdermal patch, in which case it is used as 4.6 milligram per 24 hours, applied to a clean, non-hairy site, and it's removed from that site. And that new patch should be applied at a different site. If care is not taken, then repatching can lead to an overdose, which can also be fatal. If the patch is tolerated well, then the maintenance dose should be 9.5 milligram per 24 hours patch daily. And tolerating it for much more time will lead to a further increase to 13.3 milligram per 24 hours daily. Side effects are slightly similar to acetylcholinesterase inhibitors. They would be hypersensitivity, dermatitis, problems in pregnancy and breastfeeding, and the usual ones: nausea, vomiting, diarrhea, dyspepsia, anorexia, weight loss, abdominal pain. There would be bradycardia, headaches, drowsiness, agitation, anxiety, and tremor. So the main caution would be with hepatic and renal impairment, gastric ulcer, and sick sinus syndrome. If there is a history of asthma, seizure, and bladder obstruction, one should avoid rivastigmine. So if acetylcholinesterase inhibitors are not used, or if the patient doesn't tolerate it or have not been effective, then the specialist initiated memantine can be used as 5 milligram daily, increasing weekly to 20 milligram per day. But one should not exceed 10 milligram dose per day if the EGFR is reduced and is between 30 to 49. But if the EGFR is less than 30, then it should be a specialist intervention, possibly followed up by the specialist. The side effects of memantine are GI tract, hypertension, dyspnea, drowsiness, impaired balance, and less commonly, vomiting, thrombosis, heart failure, confusions, fatigue, and seizures, pancreatitis, psychosis, depression, and suicidal ideation. The drug interaction is usually with antimuscarinic, such as amitriptyline and chlorphenamine, solifenacin, etc., with antipsychotics, mainly olanzapine, barbiturates, and muscle relaxants such as baclofen. There is great interaction also between warfarin and NMDA N-methylated D-aspartate antagonists such as amantadine and ketamine. So how does one treat the patient? And we are coming to nearly the end of my presentation. The anticholinesterase inhibitors are used for Alzheimer's disease by way of monotherapy for mild to moderate Alzheimer's disease. Memantine can be used as monotherapy for Alzheimer's disease, or if the patient is intolerant of acetylcholinesterase inhibitors. Memantine can be added to donepezil or rivastigmine if needed. When someone has non-Alzheimer's dementia, use of memantine is unlicensed, but can be specialist prescribed depending on their experience and on their monitoring. For patients who have dementia with Lewy bodies, first-line treatment is donepezil or rivastigmine. Galantamine can be added if donepezil and riva are not tolerated. For vascular dementia, or if patient has additional Parkinson's disease or dementia with Lewy bodies, then one could use acetylcholinesterase inhibitor or memantine. The examples would be donepezil, galantamine, and also rivastigmine or memantine. If someone has frontotemporal dementia or PIC dementia, then one must not prescribe acetylcholinesterase inhibitors or memantine. So we have come to the end of my presentation, and I hope that you have taken note of some of the old and some of the new information and the guidelines from NICE 2020 on which I've based my presentation. And I hope that you have made some use of it. I wish you good luck and hope that you are able to apply this knowledge in your management of dementia of various kinds. Thank you very much. Thank you. Bye-bye.